back to the emergency medicine lecture series. In today's class, we are going to discuss about the emergency department arterial blood gas analysis. I am Dr. S. Prakash Babu, Assistant Professor and in charge, Department of Emergency Medicine, PSMSR Kuppam. Before going into the ABG analysis proper or the collection of ABG, you need to know certain basic concepts and how the acids and bases are handled in the body. Most important thing is pH. pH is a measure of hydrogen ion concentration. Aqueous solutions at room temperature, the pH less than 7 are called acidic. Those with pH greater than 7 are called alkaline solutions. The normal physiological pH is around 7.4. How acids and bases are handled in the body? Production of acid in the body, mostly in the form of carbon dioxide, which accounts to 15,000 millimoles per day, and also non-volatile acids, which are up to 100 milliequivalents per day. Once produced by the tissues, where does it go? Most of the acid is renally excreted, and also carbon dioxide can be excreted by respiratory elimination. Production of bicarbonate in the body is mostly renal and occurs as a compensatory response to chronically increased carbon dioxide. So this picture here shows how the acids and bases are handled. In the cells, metabolism occurs and two types of acids are produced: volatile acids in the form of carbon dioxide, non-volatile acids in the form of hydrogen ions. They enter the bloodstream. In the bloodstream, there is an enzyme called carbonic anhydrase. In the presence of carbonic anhydrase, CO2 binds with water and forms carbonic acid. This carbonic acid is a weak acid and can easily dissociate. It dissociates into H plus ions and bicarbonate in buffer. It reaches the kidneys through the bloodstream. In the kidneys, again the carbonic acid is broken down into bicarbonate ions and H plus ions. The H plus ions are excreted. So the blood entering back into the general circulation from the kidneys has less proteins than the blood which entered the kidneys. Again, there is buffering action. Acids and bases will come into equilibrium. Again, CO2 and water combine to form carbonic acid at the tissue level. The more acids in the blood and less bicarbonate buffer. Once it reaches the lungs, again the carbonic acid is cleaved into carbon dioxide and water. This carbon dioxide is volatile and is eliminated through the expired air by alveolar capillary membrane. Next concept is the base excess, or also called as base deficit. Base excess is defined as the amount of strong acid that must be added to each liter of fully oxygenated blood to return the pH to 7.4. In other words, a base excess of -6 means we will have to add 6 millimoles of bicarbonate to get a pH of 7.4. The actual base excess that is present in the blood, while the standard base excess is the value when the hemoglobin is at 5 gram per cent, because hemoglobin will be buffering the bicarbonate, and in presence of higher hemoglobin values the buffering is more and bicarbonate will be less. If you take the bicarbonate value that would be present when the hemoglobin is 5 grams per deciliter, that is called the standard base excess. Base excess can be calculated by the formula 0.02786 into PaCO2 into 10 into pH minus 6.1 plus 13.77 into pH minus 124.58. Normal value of base excess would be +2 to -2. Positive base excess numbers indicate presence of metabolic alkalosis, whereas negative numbers indicate presence of metabolic acidosis. One more most important concept in acid-base balance is the Henderson-Hasselbalch Equation. It is used to calculate oxygen ion concentration of a buffer solution. The formula is given as pH equal to pKa plus logarithm base by acid. Chemical equation at equilibrium in the human body as I told earlier, it's CO2 plus water in the presence of carbonic anhydrous enzyme combines to form carbonic acid. Carbonic acid is a weak acid, immediately dissociates into bicarbonate ion and the H plus ions. So the whole reaction is in equilibrium. As carbonic acid in the body is negligible, the following equation can be applied to derive Henderson-Hasselbalch equation in human body. pH equal to 6.1 plus log of bicarbonate divided by 0.03 into PCO2. The next concept is conservation of charge. There are positively charged ions and negatively charged ions in the body. Positively charged ions as sodium balance the negatively charged ions like chloride, and this happens as a priority in the human body. Compensatory buffering with bicarbonate or protons occurs to compensate for imbalances in the charge. So when the charge is priority and conservated, this electron neutrality is maintained in the body. Then again, why there is an anion gap? The anion gap reflects the difference in the serum concentration of measured cations to that of unmeasured anions and is calculated using the following formula. Anion gap equal to sodium plus potassium minus chloride plus bicarbonate. But we need to incorporate the unmeasured cations and unmeasured anions too. When you incorporate those, the formula becomes sodium plus potassium plus unmeasured cations minus chloride plus bicarbonate plus unmeasured anions. So what are these unmeasured ions? Unmeasured cations are mostly positively charged proteins, also calcium and magnesium. At non-physiological stages, they are very negligible and they cannot affect the acid-base status of the body to a greater extent. Unmeasured anions, negatively charged proteins, non-carbonic acids that are produced during the physiological and pathologic processes like lactate, phosphates, sulfates, and ketones. When there is alteration in the metabolism, these substances can accumulate to a greater extent and cause a proper change in the acid-base status or the charge status of the body. Electron neutrality is not maintained. Hence, these unmeasured anions have to be taken into consideration when you are looking at anion gap. These are the ions that are responsible for creating an anion gap. Now, why do you need to take blood gas in emergency department? How does it help you? Arterial blood gas result can help in the assessment of patient's gas exchange, ventilator control, and acid-base imbalance. It also helps the guide management of sepsis, respiratory failure, and cardiac arrest. Point of care testing is very fast and can speed up the IV contrast imaging by letting you know the creatinine early, and also it tells electrolyte imbalances and allows you to correct the electrolytes early. It also aids in ventilator management by giving you repeated values of carbon dioxide. You can use ABG when you are following either invasive ventilation or non-invasive ventilation. What is the information obtained by doing an ABG analysis? It's not only the acid-base status in the body, you can estimate ventilatory status, that is carbon dioxide removal, oxygenation status by arterial oxygen concentration. It helps you quickly assess for electrolytes and creatinine. It also gives you lactate, hematocrit, and hemoglobin. So there are certain contraindications to collect an ABG sampling: local infection, distorted anatomy, presence of arteriovenous fistulas, peripheral vascular disease of the limb to be sampled, and severe coagulopathy or recent thrombolysis are the contraindications. Before going into analyzing the ABG, you need to know the normal reference values. First, arterial blood gases, pH is 7.35 to 7.45, pH O2 is 80 to 100 mmHg, PaCO2 is 35 to 45 millimeters of mercury, bicarbonate is 22 to 26 millimoles per liter, base excess is -2 to +2 millimoles per liter. Is there a difference when you compare with venous blood gases. Yes, the pH is slightly lower, which is 7.32 to 7.43. The venous oxygen saturation is 25 to 40 millimeters of mercury. The venous carbon dioxide saturation is 41 to 50 millimeters of mercury. Bicarbonate concentration is 23 to 27 millimoles per liter. So now we are entering into the ABG analysis proper. The easiest way is the 6-step approach. The first step is assessing the internal consistency of the values using the Henderson-Hasselbalch equation. You need to be sure that you are looking at a perfect ABG and you can rely upon the values. For that, you need to assess the internal consistency. It is given by the formula H plus equal to 24 into PaCO2 divided by bicarbonate. H plus can be derived from the pH by anti-logarithm, which is given, and some ABGs show you directly the H plus concentration which is measured. This measured H plus concentration should be equal to the calculated hydrogen ion concentration. If this is the case, then your ABG is said to be internally consistent and you can rely upon the values. The pH and the H plus are inconsistent. The ABG is probably not valid. You might need to repeat or recheck your equipment. Step 2 is there alkalemia or acidemia present? If pH is less than 7.35, it is called acidemia. If pH is greater than 7.5, it is called alkalemia. Usually, the direction of change of pH is the primary disorder. Remember, acidosis or alkalosis may be present even if the pH is in the normal range because of complex metabolic alterations. You will need to check PaCO2, bicarbonate and the anion gap. Step 3, find out whether the disturbance is respiratory or metabolic. For doing this, you need to check the relationship between PaCO2 and the pH. In primary respiratory disorders, the pH and PaCO2 change in the opposite directions. In primary metabolic disorders, pH and PaCO2 change in the same direction. Let's see how this happens. If you check in respiratory acidosis, the pH is decreased, PaCO2 is increased. So they're changing in the opposite directions. Metabolic acidosis, pH is decreased, PaCO2 is also decreased. So the change in the same direction. In respiratory alkalosis, pH is increased, PaCO2 is decreased. So the change is opposite, hence it is respiratory. Metabolic alkalosis, pH is increased and also PaCO2 is increased in the same direction. So in metabolic disorders, pH and PaCO2 change in the same direction. In respiratory disorders, they change in the opposite directions. Step 4 is to calculate the appropriateness of compensation for the primary disturbance. Usually compensation does not return pH to the normal. If pH is in the normal range and you see an acid-base abnormality, it might be a complex acid-base abnormality. These are the formulas you need to be using for detecting different types of acidosis. There is a metabolic acidosis, PaCO2 should be equal to 1.5 into bicarbonate plus 8. Acute respiratory acidosis, increase in bicarbonate should be equal to the decrease in PaCO2 divided by 10. In chronic respiratory acidosis, increase in bicarbonate should be 3.5 times the decrease in PaCO2 by 10. Metabolic alkalosis, increase in PaCO2 is equal to 40 plus 0.6 into change in bicarbonate. In acute respiratory alkalosis, decrease in bicarbonate should be equal to 2 times delta PaCO2 divided by 10. Chronic respiratory alkalosis, decrease in bicarbonate should be equal to 5 to 7 times the change in PaCO2 divided by 10. Step 5 is calculation of the anion gap. If there is a metabolic acidosis exists, you need to calculate the anion gap. A normal anion gap is approximately 12 milliequivalents per liter. If there is hypoalbuminemia, because albumin is the most important protein buffer system. There will be alteration anion gap. If hypoalbuminemia exists, for every 1 gram percent decrease in albumin, you need to add 2.5 milliequivalents per liter to the calculated anion gap to attain the actual anion gap. If the anion gap is elevated, consider calculating osmolar gap. Elevation in anion gap is not explained by an obvious cause like lactic acidosis, renal failure. You need to look for toxic ingestion. Osmolar gap is equal to measured osmolality minus calculated osmolality. Osmolar gap should be less than 10. The final step, if an increased anion gap is present, you need to assess the delta ratio. Delta ratio is assessed by the formula change in anion gap divided by change in bicarbonate. If it is from 0 to 0.4, there is a normal anion gap metabolic acidosis. 0.4 to 0.8, there is mixed normal and raised anion gap metabolic acidosis. 1 to 2, raised anion gap metabolic acidosis. Greater than 2, metabolic acidosis with a coexistent metabolic alkalosis or a compensatory respiratory acidosis. The characteristics of acid-base disturbances. In metabolic acidosis, pH is decreased. Primary problem, bicarbonate is decreased. Compensation, decrease in PaCO2. Metabolic alkalosis, pH is increased, bicarbonate is increased, and also PaCO2 is increased. In respiratory acidosis, pH is decreased, PaCO2 is increased, and bicarbonate is increased. Respiratory alkalosis, pH is increased, PaCO2 is decreased, also bicarbonate is decreased. So how do you interpret an arterial blood gas result? If pH is less than 7.35, you call it as acidemia. The presence of acidemia, next step you need to do is look at the PaCO2. If PaCO2 is high, that is greater than 45, you need to look at the base excess. If base excess is positive or greater than 2, it's a primary respiratory acidosis with renal compensation. If base excess is within the normal limits -2 to +2, primary respiratory acidosis. If base excess is negative, mixed respiratory and metabolic acidosis. If the PaCO2 is normal and there is acidemia, look at the base excess. Base excess is negative, it's a metabolic acidosis. If PaCO2 is low, less than 35, and base excess is negative, less than -2, it's a primary metabolic acidosis with respiratory compensation. Interpreting alkalemia, look at the pH greater than 7.45. Then look at the PaCO2. PaCO2 is high. Look at the base excess. Base excess is positive or greater than 2. It's a primary metabolic alkalosis with respiratory compensation. If the PaCO2 is in the normal range and there is a positive base excess, there is primary metabolic alkalosis. pH greater than 7.45, PaCO2 is low and there is positive base excess. It's a mixed respiratory and metabolic alkalosis. If PaCO2 is low and normal base excess, it's primary respiratory acidosis, alkalosis. PaCO2 low, negative base excess, it's primary respiratory alkalosis with metabolic compensation. Next, most important thing you can look at in the ABG is the arterial oxygen saturation. This reflects gas exchange in the lungs. PaO2 decreases with age. Expected PaO2 when breathing air at sea level can be calculated by the equation PaO2 equal to 100 minus age by 4. PaO2 that is less than expected indicates hypoxemia. If alveolar ventilation is adequate, that PaCO2 is normal, and the hypoxemia is almost certainly caused by a ventilation perfusion disturbance. Then you can calculate the alveolar-arterial oxygen tension difference. Normal range is 5 to 15 millimeters of mercury. Oxygen gradient can be calculated by FiO2. If you're breathing a room air, the FiO2 is 21% or 0.21. For every 1 liter of supplemental oxygen, FiO2 rises by 4% or 0.04. FiO2 into atmospheric pressure minus water vapor pressure minus PaCO2 by respiratory quotient. Respiratory quotient for human body is 0.8 minus the measured PaO2. An expected alveolar arterial oxygen tension difference can be calculated using the formula 3 plus 0.21 into patient's age. An arterial oxygen greater than 15 mm Hg says ventilation perfusion mismatch related to disease of the airways, lung parenchyma, or the pulmonary vasculature. So what are the factors influencing the blood gas results? Delayed processing of sample may yield falsely low PaO2. Air bubbles introduced when performing the arterial puncture can also cause falsely high PaO2 and falsely low PaCO2. Body temperature can also affect the arterial blood gas tensions. There are certain limitations to the blood gas analysis. First and foremost, it tells you only the acid base status in the body. It cannot give you a specific diagnosis. Similarly, the absolute values which you look in the ABG will not reflect how much they are affecting the patient. A low PaO2 does not necessarily indicate tissue hypoxia, nor does a normal PaO2 indicate adequate tissue oxygenation. Blood gas analysis cannot be used as a screening test for early pulmonary disease. Before you see any changes in the blood gases, there is already a severe pulmonary disease. Thank you.